your invitation. This is a way to share my ideas and thoughts about especially this type of patients and treatments. And I appreciate that you can give me a way to talk about this topic, such as power of growing and power of Invisalign system. So, but I hope to share with you something useful about ideas and thoughts and way to treat, especially about this type of patients and about my job and my practice. And so I'm so honored, really honored to be here with you. And I've always been interested in therapy on patients in developmental age. I'm a speaker for Align Technology, but I always share my lectures, especially about growing patients. But in the recent years, this company, as focus is attention, is efforts, is researches, is protocols, is studies, especially about this type of patients, this category of patients. I come from Rome, Italy. Uh, I I studied here, and my family is here. My work is here, but I was born in the south of Italy. But at the moment, of course, my life is in Rome. I'm a visiting professor in Catholic University and Tor Vergata University, and I have a great collaboration with the San Filippo Neri Hospital, where we treat patients with craniofacial problems, especially about the surgery and maxillary surgery and this type of patients. I hope that all my point of view is useful for you to face some specific topic about growing patients. We know that we have to visit our kids, our patients, no later than age 7. This is an important document that we can find in the American Association of Orthodontists. And they said that they wrote that it is very important to visit our kids, especially no later than age 7, because we are able to guide the mandibular and maxillary bone growth. We can avoid the risk about trauma on anterior teeth, and we can correct, for example, oral habits, so important to find, especially in this recent generation. And we can improve better the appearance, and we can guide the eruptions. We can analyze exactly what can happen from deciduous dentition to mixed dentition and to permanent dentition. We can improve better the muscles around the mouth, because it is very important to analyze not only the skeletal tissues and the dental tissues, but also the soft tissues, especially about around the mouth and the intraoral forces, for example, the tongue and its function. I usually use Invisalign first, and its protocol so important for me, because I would like to share with you what I found in my treatments, especially because I believe in intercepted orthodontics, in early orthodontics, so important for me. And I try to find some definitions, for example, Profit and Thompson and Ackerman and other important researchers about the intersective orthodontics, and the definitions. I think the most important definition are those, and especially about Ackerman and Profit. They said that all simple procedures that eliminate the worsening of malocclusion. So they were talking about simple procedures. This is an important adjective for me, simple, because with simple we can focus our attention to simplify some treatments, especially about the kids, because this is an important consideration, important topic that we had to fix in our mind. Simple procedures, so important. So for me, we need to consider the goals, because we had to prevent the negative components that are known to worsen in the second time. We can correct the simple the evolution of the development. We can remove the negative factors. We can reduce the severity of the skeletal alteration. We can use simple and procedures to have a way to follow the evolution of dental elements too. So the goals are very important to know very well. And again, the benefits, the positive effects, especially if we are able to do a correct diagnosis and then to use a perfect appliances for each malocclusion to prevent the worsening of malocclusion. But so we can use this timing, this phase of the evolution of a specific patient, because we are able to reduce the extractions in the second phase. For example, we are able to reduce the timing in the second phase, or absolutely we can avoid the second phase totally. We can reduce the treatment with the surgical treatment, surgery. We can have a perfect expansion that we can serve in the second phase. We can increase the stability of the alignment of the lower incisors. We can reduce the problems about the soft tissues around the roots, about our teeth. We can reduce the problems about the eruption of the canines. Very important, this topic, no? Especially if we can analyze better the inclination of the canines. So what is the indications? The indications of early orthodontics are many ones. So for example, anterior crossbite and posterior crossbite, a severe open bite or lateral open bite, or for example a problem on the transversal width, or sometimes problems about sagittal width, or for example the bite, vertical dimensions, or other problems about the evolution or the dentition or the eruptions. So from, for example, mixed dentition to permanent dentitions. But this is my personal indication. My personal indications are very, very important because they started in the first voice, in the first topic. This is the diagnosis. The diagnosis is the first thing that we have to do perfectly. The principal things, the important, more important than the other part of our treatments. This is the diagnosis. And we need to eliminate the interference, because if you are able to focus our attention on interference, we can treat, we can eliminate this interference, and we can avoid the initial of a malocclusion. So we can have short treatments, and we don't have to insist to solve everything, because we are able to focus our attention only on interference. Then we can focus our attention in the second part of the evolution of the growth to solve other things. But it is necessary only to avoid, to eliminate interference. And in digital planning, I prefer to use a completely digital workflow, because we are in an important age of our way to live, and especially the digital plan is very, very important in our work. I love this work, I love this article, because this author was able to sum up what I would like to share with you. So for me, it's very, very important to study and to know very well exactly the complex mechanisms about the craniofacial growth. We have to know about embryology, about physiology, about dentition development, about growth, and of course the way to growth, about the mandibular bone, about the maxillary bone. And it is very, very important to study for a long time, every day, the complex mechanisms about the craniofacial growth. So for me, if we know very well, if we have a great knowledge about this topic, we can use early treatments, because we can touch the interference, we can analyze the interference, and we can eliminate immediately this. So for me, knowledge is power. This is very, very, very important for us as orthodontists, because we have a great responsibilities about the growing patients especially. But I want to analyze exactly what he wrote in this article, and what we can analyze during our treatment, our cases. And the first voice is very important: occlusal development, and in the interaction with of craniofacial growth. So I know that the occlusal problems can have an important consequences on the craniofacial growth. For example, Carson said that the 80% of craniofacial growth is completed by the age of 6 to 8 years. And so only the vertical facial dimensions, as Enlow said, is the last dimensions that we can follow after the pubertal stage. But for me, it's very, very important at the first thing to analyze the transversal dimension, because in this age it's very, very important that we have this part of growth in relation to the environmental factors and not in relation to the genetic factor. So now I would like to share exactly what I did, for example, in this case, Chiara, because I think we can do our analysis about air interferences. And this is the smile, the profile, and we have many problems, especially about the transversal with in the upper jaw. So we have a narrow upper arch with the anterior crossbite, and I have a severe deep bite, a severe overcrowding. So I think it is necessary to do something for her. I know that we are in the mixed dentition. We are many elements that she has to change, but it is not important for me because I would like to start immediately, especially because I'm so convinced that I have many problems in the anterior part about the crossbite. So I want to start immediately. Using this way to analyze, you can look at on the upper part of my slide exactly what we can have during the analysis in OrthoCAD. OrthoCAD is a system, is a software that you can find using the Heteroscan, and this is a linked software with Hetero. And we noted that immediately with occlusogram analysis that we have a strong contacts in soft tissues. If you are only the analysis from CleanCheck, you can have a perfect diagnosis at the beginning of your treatment. Why? Because the CleanCheck is not able to show the perfect situation about the soft tissues. So we can start with this view in CleanCheck, but if you compare exactly the same view by OrthoCAD, we can discover that we can find out that we have a strong contacts between the central incisor and the lateral incisors on the palatal surface of the upper arch on the left side, so on the right side. So this is an important interference that I noted using occlusogram in OrthoCAD. Occlusogram function in OrthoCAD. So I try to find my attention, especially on this interference. And this is the CleanCheck. Of course, I need to correct the crossbite. I need to use a perfect expansion of the upper arch with the rotation in mesial out. I need an extrusion, relative intrusion, because using this type of correction, an intrusion and a proclination of the incisor, we can have a better intrusion, a relative intrusion. So this is a way to use exactly the CleanCheck, analyzing the transversal dimension, especially on the expansion and with the correction of the crossbite and the anterior part vertical dimension, using again I would like to share with you the intrusion and the proclination, so we can have a better correction of the deep bite. exactly what I have about the expansion, just a little sequential expansion, because I started the beginning with the first molars and then with the other part of the arch. This is the eruption compensation, because I have many elements without the crowns. So during my clean check, I use eruption compensation instead of, for example, the right canine or the second or the first premolar in the upper arch. I need to change every 5 days. Why every 5 days? This is my protocols. When I have an anterior crossbite, I try to go fast. So only way to go fast is without using nothing special attachment or bite rams. No, it is necessary only to go fast. So 5 day changing is the best way that you can do, especially if you have an anterior crossbite. Okay, so this is my project because I got another degree in my life, a secondary degree in architecture. So I try to plan exactly my arch. And in this way, I try to use the perfect width before and after, and to analyze exactly what is my expansion, how I can have this perfect expansion. We know that if you want to have a perfect class 1, you can have exactly the position of the mesial palatal cuspid of the first molar of the upper arch, exactly inside the sulcus of the first molar of the lower arch. All in this case, you have a perfect class 1, dental class 1, not only using the classification of angle, but we have another classification looking at the palatal view. So we have a perfect class 1 if we have the mesial palatal cuspid, the first molar of the upper arch, that can go on exactly in the sulcus of the first molar on the mandibular bone. So if I have a perfect width of the mandibular bone, I need to repeat exactly this view, this width, for the upper arch. I would like to share with you because I analyzing the lower arch, and I discovered that I need to have this perfect width for upper and lower jaw, exactly at the end about of 44 millimeters. And the other things that I try to analyze is the mesial out of the first molar of the upper arch. Using what? Using the Ricketts line. The Ricketts line said that we have a perfect position of the first molars of the upper arch only if we have this line that we can join that exactly the buccal distal cuspid and the mesial palatal cuspid of the first molars. This line can go on in the canine on the opposite side. So only in this case we have a perfect position, a perfect rotation of the first molar. So I'm planning perfectly my expansions and my position for the first molars. Exactly in the architecture we have a Gothic arch when we started, but at the end of our plan we have a Romanic arch. So I prefer Romanic arch instead of Gothic arch, because we have not only a perfect width in the posterior part of our arch, about especially the width between two first molars, but also between the canines. So important for us because Only in this case we are able to reduce the overjet and the trauma in anterior part of our mouth. So I said that the first time I'm looking exactly the expansion for the lower jaw, exactly 44 millimeters, between these 2 points, inside, exactly in the middle of the sulcus of the first molar of the mandibular bone. So I have 44, and I need to repeat exactly this width in the upper arch, exactly between, I said before, between these 2 points, between these two mesial palatal cuspid of the first molar for upper jaw. 44 millimeters, exactly the same, because I need to have a perfect class 1 occlusion. So I started immediately for many reasons, because I would like to avoid immediately this interference, especially in the anterior crossbite. But I noted that I have a crowding in the anterior part, and I'm losing the leeway space, because I need to stop the mesialization of the first molars in the lower arch especially. And because I know that using this changing from secondary the second more deciduous molars to the second premolars permanent dentition, I have more space, and I need to use this space because I need to correct the crowning anterior part. So I'm using the leeway space. I stopped the position of the first molar using the attachment and using the aligners. After 5 months of therapy using the first phase of the Invisalign system, I'm waiting for the permanent dentition, and so I need to improve better, of course, my evolution. And so I started with the second phase, only 20 aligners. So I use other 5 months of therapy. And this is, of course, my second clean check. And with the other permanent dentition, the first premolars. Okay, and this is the evolution. Just a little improvement about the expansion. Of course, before and after, the smile and the perfect intrusion. And of course, starting the second phase, yes, I noted that I have an improvement about the deep bite, about, for example, the middle line, about the crowding, the correction, the crowding on the lower incisors. But of course, I need the second time. And this is finishing, starting the third phase, finishing the second phase, starting the third phase, because I need to improve better the position of the permanent dentition. And of course, I have a second deciduous molar in the upper arch, and I'm waiting for this changing because I know that we could have a perfect position for the second premolar. But looking at the evolution of the arch form, the upper arch, we have at the beginning of our treatment a triangular form. Then we have specifically this ovoidal form, arch form, so different, because we have a perfect expansion, we have a perfect rickets line, and so. So I need to start with the second phase. I prefer to use this name, phase, not refinement, but phase, because in this case, when we need to follow the evolution of the dentition or the eruption, we can call refinement this phase in Invisalign technique, but we can call first phase, second phase, and third phase. Why not? So the first phase 5 months, the second phase other 5 months, and the third phase 4 months of aligners. So this is the evolution of the third phase, just a little improvement, and to put better the position of the permanent dentition. And this is the end of the third phase with her smile and profile and the solution. Of course, I need to wait for the second premolars, but I have a perfect space, a perfect dimension for the second premolars. And so before and after, with about the transversal dimension, a perfect values about the vertical dimension, and about the crowding of the lower incisors. So starting with this type of occlusion, we finish with this correction, with this improvement about the deep bite and the crowding of the alignment of the lower incisors. Before and after, and this is new arch form about the upper arch especially, and the perfect position of the canines. And of course, you can look at the posterior torque, because for me it's very important to analyze the grabber. Grabber said that it is very important to put exactly in the perfect position the roots in posterior part. So we have a perfect torque if you are able to put in this position the lateral torque, because in every situation, especially in our kids, in the recent generation, in the recent patients, we can have in every situation a super negative torque in posterior part. You can listen to me, because it is very important to analyze our kids. It is not necessary a therapy only when we recognize that we have a posterior crossbite, an evident posterior crossbite, but also when we have a super negative posterior of the crowns. When you have this situation with this type of position, this super negative torque in posterior part, you have to focus our attention about exactly the width on the posterior part. So in this case, I think in every situation that you can face during your work, you can look at immediately in the posterior part, and you can start immediately, not only if you have an evident dental crossbite, posterior crossbite, but also when you have this situation with this super negative torque in posterior part. But now I need to share with you what we can have in genetics and environmental factors, because we know that, and I said before, during the embryonic period we have the important work of the genetic factors, but after, during the other part of our life, the environmental factors have a great influence, especially during the permanent dentition, during the mixed dentition. They have a great influence. So Believe me, it is very important when we have a mixed dentition to have a perfect analysis about the environmental factors that can have a negative effect on our kids. So again, I want to share with you another case, Luca. Luca, I have many problems about the position of the permanent dentition. And so I need many problems about the cavities, of course, the hygienes, but I need to focus my attention on orthodontist treatments. I need to follow him for a long time, I know, but in this case, in this moment, I need to correct the anterior crossbite. And I said for Chiara, do you remember? We had to go fast. It is necessary to change every 5 days. 5 days, the aligners. Not 7 days, but 5 days only if we have a crossbite, an anterior crossbite. So I have many problems with Luca, I know, and I try to plan, of course, my solution with some attachments and expansions about the upper and lower arch, of course, with just a little sequential expansion, because I try to start at the first with the first molars and then with the other part of arches as a sequential distalization, the same. And this is the sequential expansion, exactly. The first molars and then the other part of arches, exactly, in this case. And because I think it is very important to start with the movements of the first molar at the beginning, just a few phases with this, only moving the first molars, very important to start to have immediately the activation of some cells inside around their roots, of course. And this is the view that can help us to analyze better what we have. You can recognize that we have a deep bite, of course. The other part, we have a cross bite. Exactly on the left side, a severe cross bite. You can analyze with this type of views on clean check. And so, again, orthogad. And the occlusogram analysis from orthogad. Orthogad, because with orthogad we have the soft tissues. And using my analysis with the occlusogram, we can recognize that we have many problems about the soft tissues. And especially because we have an anterior negative strong contacts between the lower incisors and the soft tissues of the maxillary bone. So I need to avoid immediately eliminate immediately this interference in the anterior part, especially because I don't want to go on with this type of growth, especially because I don't want to have these strong contacts between the incisors and the soft tissues for upper arch. And using the sessions, we can have these sessions and we can have the perfect analysis exactly here about the lateral incisors with the lower arch. And you can recognize that we have a strong contacts there, and we have a strong contacts in between the incisors. And again, about this, the lateral incisor on the right side too. And you can look at the contacts with the soft tissues or the palatal tissues. So I need to improve. I need to have a perfect expansion. We have the narrow upper arch again in compared to the mandibular arch. So this is exactly what is the width between upper and lower arch. And I need to improve better the expansion using the end of the expansion of the lower arch, 44 millimeters. No more than 3-4 millimeters, no more, because we don't have to exaggerate with the expansion. Only 1-2 millimeters per side. Okay, so in the upper arch I need to have the perfect position of the mesial palatal cuspid of the upper arch that can go on exactly in the sulcus of the first molar of the mandibular bone. Exactly using this perfect width between upper and lower jaw, we have a perfect class 1. So I need to have a perfect rotation of the first molar using what? Ricketts line again, because I need to join the buccal distal cuspid and the mesial palatal cuspid of first molars. They can go on around the canine on the opposite side. So using this perfect rotation for the first molar, we can have a perfect position for the first molars. Again, using the architecture, I prefer to have a Romanic arch instead of a Gothic arch. Why? Because I can prevent the trauma in anterior part. And you look at we have done an anterior trauma. So in this case, I need to have a perfect expansion about the molars, but also a perfect expansion about the width of the canines. In this case, with the perfect expansion, we can reduce this width, we can reduce the overjet, and we can reduce the trauma in anterior part. Exactly, this is the expansion for the lower arch, 44 millimeters, and we need the same, exactly the same width for the upper arch between these 2 points, the palatal mesial cuspid for upper arch. Okay, so we need to go fast because we can change every 5 days again, and I use 5 months of therapy. This is the evolution. An improvement, of course, a correction, the anterior crossbite, the deep bite, and the trauma in the anterior part. And so a perfect expansion in the upper arch, and a correction of the middle line because we have a shift of the mandibular bone caused because of the anterior crossbite. And we started with this situation, with this strange, severe situation. And we had, after 5 months, another scan with this new situation. This is a new arch form. This is a new month. This is a new harmony. And before and after, the occlusal view, occlusogram, and before and after. And again, what Graber said, he said that it is very important to have a perfect torque in posterior part. And you need to analyze every cases that you face every day in your dental practice, because we need to correct not only an evident posterior cross-dental cross-bite, but also a negative superlateral, negative lateral super torque. So in this case, we need to start, and we have a perfect expansion, a perfect new arch form for the upper arch. So I want to share with you what is my opinion and what I try to sum up of this, about this article about the form and functions. So we know that what Wolf said, what Moss said, form follows function, so important for us as orthodontists. And we know that we need to analyze some phenomena around the mouth, because it is very important to analyze the muscle inside the mouth and outside the mouth, and the balance, the harmony, the relationship between what we have inside and outside. It is very important to analyze the breathing, because the breathing is very important, and we have many problems about the maxillary bone if we don't have a perfect breathing, if we have many other problems about the respirations and its functions. We have many problems about the position of the head, and at the same time we need to analyze this because it is very important, and we need to analyze the oral habits too. Many problems about the oral habits, especially in the recent generation, especially. So we know that, again, we start to have an early diagnosis. We need to have an early diagnosis and an early therapy. It is very important, especially in this case, because using a way to redirect the function, we can redirect the form. So important. Again, another case, Georgia. I know that I have a severe class 2 malocclusion, but I don't want to take care about these dimensions, the sagittal dimension, because this is not a perfect age to start to correct the second class. I know that from the literature, of course. We know that it could be better to start a correction of the class 2 malocclusion in the pubertal stage. No? So this is the perfect age to have a perfect outcomes. You can look at about the class 2 malocclusion, about the mandibular hypoplasia, about the other problems, but I think it is very important to analyze her smile. I know that we don't have an harmony about the smile, an harmony about the face, and you can look at the class 2 malocclusion, you can look at the severe crowding, the bite, the strange position of the central incisors, and other things. This is the clean check. The clean check, you can look at the anterior contacts, so strong. We have severe class 2 occlusion and a full class 2 occlusion, and we have this arch form exactly with a V pattern. So we have to improve better the dimensions, about the transversal dimension, of course. And this is the occlusogram. from AutoCAD again, so important for us to have this type of analysis, because in this case we are able to analyze the contacts in anterior part with the soft tissues in the maxillary bone. So I noted that I have many problems about these anterior contacts, but also about the canine. I need to improve better, not only the expansion of the molars width, but the expansion of the canine width. So important for me. And of course, I noted that using the sessions, the analysis of sessions, that we have many problems, especially about the canines, and I need to improve better the expansion about this width between these two canines in the upper arch. You can look at this super negative torque of this canine. And of course, I have a class 2 malocclusion for this reason. Because we don't have a perfect position of the mandibular bone, because we have many interference. So I focused my attention only on the interference, only on this, only on the transversal width, and not on the sagittal dimension. Again, I noted that I have a narrow upper arch in compared to the lower arch, of course. And again, I need 40 millimeters of expansion. Again, I need to have a perfect width between the upper arch and lower arch. Because I started with the expansion of the lower arch, and I need for the lower arch 40 millimeters between these 2 points in the middle of the sulcus, but I need to have this width between these 2 points, between the cuspid, mesial palatal cuspid of the first molars, and the other mesial palatal cuspid of the first molars on the opposite side. And this is exactly the width that I would like to have at the end, 40 millimeters. And the rotation using the Ricketts line. So this is exactly the mesial out, the value of this type of rotation that I would like to have using the Ricketts line again. I prefer Romanic arch in compared to Gothic arch. I prefer to have a perfect situation, a perfect arch form about the upper arch, especially because using a perfect expansion of the molars and using the perfect expansion between the canines, we can have a perfect overjet too. We can reduce the overjet, and we can reduce the events of trauma in anterior part. And of course, 40 millimeters for the lower arch. So after 4 months of therapy, Georgia was with this new smile and just a little improvements about the position of the incisors and the alignment on the upper arch. This is the evolution of the upper arch after 7 months of treatments, with a new arch form for the upper arch, following the perfect width between upper and lower arch. And this is the evolution after 7 months of therapy, before and after, and the evolution, and just a little improvement about the class 2 malocclusion. Just a little improvement. Why? Because we were able to avoid, to eliminate the interference. Of course, this is a view from OrthoCAD, and with the occlusogram function opens, And so we have at the beginning of treatment this type of occlusion, and at the end of this first 7 months of therapy, this type of solution. Again, we can start with the therapy if we noted a super posterior lateral negative super torque. And this is the evolution for the upper arch. And just a little improvement, and you can look at exactly after other months of therapy what we can find about, especially about the new position of the mandibular bone. We have a new position of the mandibular bone because of ability to analyze the interference. Only this. Second X-rays, and you can look at immediately A and B2 from 4 to 2. So without nothing special, we were able to focus our attention on interference, and we correct immediately this type of problems. And you look at exactly the position of the canines, the permanent dentition. We need to follow the evolution of the permanent dentition, of course. And before and after, and this is what I suggest you have not only to analyze the cephalometric values, because this is very important to analyze the cephalometric values, but sometimes it is necessary only to look at the posterior plan. The posterior plan, immediately we can have a suggestion that we have a new position of the mandibular bone. Before and after, just this, without A and B, without S and B, without SA and A. It is necessary only to look at the posterior part of your X-rays, before and after. Georgia now is with this situation, and the profile on Frankfurt line, of cutaneous line, of course, and just a little improvement of the position of the mandibular bone. And this is the situation on the soft tissues, so important for me, and the smile too, very important for me. And before and after, again, what we can do only with the simple procedures, and before and after with this severe negative posterior super torque. Only using this analysis we can have a new position of a new arch form for the upper arch, and of course a new position for the mandibular bone, without nothing special. Okay, so this is the evolution of the profile. And you can recognize that we have a new harmony. What we know about the blocked conclusion? So important to analyze this, because exactly what we found with Georgia. If we are able to focus our attention on interference, to do a perfect diagnosis, to eliminate the occlusal interference, we can go on with the normal growth. And sometimes we can have a new position for the mandibular bone. So, for example, if we noted the narrow upper arch, we can correct it. If we noted problems about the transversal growth, we can correct it. And it is important to analyze the vertical dimension too, because if we have a deep bite, severe deep bite, and strong anterior contacts, we have many problems to have a natural position for the mandibular bone. And of course, the unilateral crossbite at the same time. We have other problems about the asymmetrical growth. So, especially in this case, with this blocked occlusion, we need therapy. We need intercept therapy. We need early therapy. And in this case, sometimes it is necessary to start in deciduous dentition or in early mixed dentition. So I want to share with you another case, Julia. I have severe deep bite with class 2 division 2, exactly. A severe deep bite, and this lingualization of the central incisors, especially the central incisors. And I have this again using the occlusogram analysis function in orthocat distal contacts in 2 points, point 1 and point 2. And exactly, I need to avoid these strong contacts between the hard tissues of the mandibular bone, teeth, and soft tissues of the maxillary bone, the palatal tissues. The second side, the second point is this, and you can look at what we had during the sessions and the evolution, exactly the posterior torque and the anterior contacts. In this case, we have a contacts with the soft tissues. And I want to analyze to avoid immediately these situations. You can look at the view from CleanCheck, but we don't have a perfect situation about the contacts from using analysis of the CleanCheck. But you can recognize that we have an omega arch form. So we need to improve better the expansion for the upper arch. And of course, a sequential expansion before the first molar and then the other part of the arch. A sequential expansion because I would like to follow to have an anchorage system. I need to start immediately with the first molars. Then I need to go on with the other part of my arches. So this is a way to have a perfect anchorage, because I need to start with the movements of the first molars, because I have a big teeth, I have a big roots. So it is very important to stimulate at the beginning the first molar, then we can go with the other part of arches. Again, I have a perfect width between upper and lower arch, 43 millimeters, and the rickets line. So in this case, I would like to show what I need, of course, in improvement, especially on about the upper arch. After 3 months of therapy, Julia, and this is the evolution, and you can note the movements of the first molars of the upper arch. After 7 months of therapy of Julia, this is the pictures about the face, and this is the evolution about a month. You can look at the evolution about the arch form of the upper arch, and the new inclination that the the incisors, the central incisors of the upper arch. And this is what I have at the beginning when I started. And this is what I planned on my clean check after 7 months of therapy. And you can look at that. We have just a little improvement. We have the pictures better than a clinical view, better than what we planned on the clean check. And you can look at exactly what can happen when you can recognize the interference in anterior part, a blocked occlusion. We have immediately a new position for the mandibular bone. Before and after, and before and after with the second scan. This is the occlusion on the first point and on the second point, and now we have the soft contacts between two teeth instead of teeth and soft tissues. The evolution, and this is what we have at the end of the treatments. Without therapy, only to check her, I need to take some pictures and to follow her during this phase, following only the position, the upper arch and the arch form for upper arch, before and after, and you look at the evolution and the new arch form. After pictures, the evolution. Of course, I need to follow the evolution of the permanent dentition, because we are at the end of mixed dentition and we are waiting for the permanent dentition. And on the left side, we started with a full class 2, without nothing special, only with the simple procedures, only with the focus our attention interference, we were able to have a perfect position for the mandibular bone. I want to share with you my suggestion, my tricks about the Invisalign first. At the first time, we need to work on the arch form. We need to work on the upper arch, especially. We don't need to have a big expansion. Instead of this big expansion, you can use a rapid expansion. But in this case that I show you, it is very important to remain inside no more than 4 millimeters. With the sequential expansion, before, at the beginning, you can start only with the movements on the first molars, then with the other part of arches. Very, very important. And to work with the positive torque control in posterior part. We don't need to have only the therapy, to follow the therapy only if we have a posterior dental cross, a cross bite, but we need to have a perfect diagnosis, a perfect treatment, a perfect therapy, even if we have a super negative posterior torque. Very, very important. We have a perfect balance between the intraoral and extraoral forces. For this reason, it's very important to put the position, to put the crowns exactly with a positive torque in posterior part. We need to analyze the interference with the occlusogram function, so important, because analyzing this, we are able to look at immediate interference and to focus our attention on this type of negative factors that can go on with the worsening of malocclusion. We can check the overjet in the lateral side too, because it is very important to have an anterior overjet about 2 millimeters, but a posterior overjet about 2 millimeters too. So important. And look at the vertical dimension, because it is very important in some cases that you have an hyperdivergence, not to have an extrusion on the posterior part, and in the hypodivergence, not to have an intrusion in the posterior part. So important. using, of course, the table of movements, dental movements. Other my suggestions so important. Again, we don't need to follow a big expansion. No more than 4 millimeters, no more. Very, very important to follow this type of expansion. You have to be careful with the lateral interference during the staging. Very, very important, because it is very important to have in the overjet not only in the anterior part but in posterior part, and the posterior part not only in the final position but also during the staging. About 2 millimeters in every situation, every staging in the posterior part. And the central incisor and lateral incisor be in different level. It is very frequent to find the lateral incisor exactly at the same level as the central incisors. In the final view, it's very important to have exactly the level of the palatal cuspid exactly at the same level of the buccal cuspid. Because in this case, we are sure that we have a perfect position of the mandibular or the first molars. I need to share some example with you. This is the expansion, too big, too much expansion. This is not normal. Believe me, we don't need to go over 3 to 4 millimeters. Okay. This is the second voice that we have to be careful during the staging, especially if we have a class 2 malocclusion. Because in this point of view, we have an expansion before for the upper arch, then for the lower arch. So this is very important to check this view, because in this case sometimes we have during the staging we have a strong contacts in lateral view. So we had to have the overjet about 2 millimeters, not only in anterior part but also in posterior part, not only at the end of the posterior part but also during every stages of the posterior part. And the other situation is that lateral incisors and central incisors, they can put them at the same level, but this is not what I would like to have, because this is not a great solution for the upper arch. And again, what we can have about the torque, the perfect torque about the first molars, that of course we can avoid to have a super positive crown torque. We need to have a perfect position of the root too. So this is a mistake. And so we can check in the final view to have the buccal cuspid exactly at the same level of the palatal cuspid. Exactly. This is a mistake. So only if we have these two cuspids at exactly the same level, we have a perfect position for the roots too. Remember that we have during this evolution from, for example, mixed dentition to permanent dentition, we have many tools in our hands, for example, the compensation, eruption compensation, or we can use the attachments to use, for example, to follow the eruption, the evolution of some elements that are changing. Waiting for the second phase. This is another topic that I need to share with you because it is very, very important. Because if we have an anterior crossbite without nothing special in posterior part, we can have nothing, we can use nothing special, only to follow the evolution of the eruptions. If we have a correction in the posterior part, so we have an expansion, a great expansion of the posterior part, we can use the last scan, intraoral scan, at the end of our 18 months of first Invisalign First, because we know that Invisalign First package it is only if we can use 18 months. So this is the way to follow the evolution, waiting for the permanent dentition, and we can use the last aligners just with a little movements on the dental elements, using only during the night and changing every stage, every I don't know, 1, 2, 3 months, wearing it only during the night. The same situation about the crowding, so the last scan just before the end of the 18 months of the Invisalign First. And then what we can do if we are using MA protocols, MA mandibular advancement protocols, we can use the last stage, the last phase. The name is transitional phase, using up to 15 aligners, wearing this with the precision wings, so we can prevent the relapse of the class 2 correction with the precision wings, using them 2-3 hours before to go to sleep and all nights. And the vertical malocclusion, the same situation. I think it is very, very important to use some specific appliances waiting for the second phase, using the perfect control on the anterior or posterior part, especially if we have an hyperdivergence or an hypodivergence. I try to sum up what I would like to share with you, but I think the second voices are very important for me. Yes, we know we are using simple procedures, we are using short treatments, we are using this type of therapy for our kids. They love it, but they can share their experience with their peers too. Very, very important. And we don't have the interference with the speech therapist. So important for me, because we know in many situations, in many malocclusion, the work of the speech therapist so important. And we can use Invisalign First. At the same time, they can work with our patients in association to Invisalign First. Now, I would like to share exactly what we can do in the pubertal stage. So for me, it's very, very important to share with you what I'm able to do with the teenagers too, because it is very important to analyze especially the severe malocclusion. For example, this is a severe class 3 malocclusion, and I noted that we have many problems about around the mouth, especially about the function of the muscles. So I know that I have many problems. I have many deciduous teeth in this case. I have a severe class 3 malocclusion because I have A and B less than 3 degrees. I don't have a familiarity to class 3 malocclusion. So if I don't have familiarity, I'm sure that this malocclusion is because the problems about the tongue or the dental interference. I would like to share with you this case because it is very important to analyze what I have at the beginning of my malocclusion, because I noted interference again, especially on the left side of my occlusion and especially about the tongue. I have many problems about the tongue. This strain position, this strain posture about the tongue, so important to work exactly at the same time with the speech therapist too. So I noted that if we have a problems about a transversal dimension, especially in class 3 malocclusion, we have a monolateral posterior crossbite. So in this case, I need to have a perfect width again between upper and lower jaw, but I know that we have a shift. So it is necessary to focus our attention on interference again. And I'm analyzing this from this range of views, from clean check. I have many interference, especially on the left side, especially because I have a shift of the mandibular bone. So in this case, I have a compensation, a consequences, a compensation of class 3 malocclusion, and this is a lingualization of the lower incisors. So I need to be careful about this situation because I need to have a new position for the lower incisor too. But I know that this is a compensation of class 3 malocclusion, a compensation of a interference about this situation, this strange situation. So in this case, I try to use a function appliances, my functional therapist that was able to follow a new function for the tongue, and at the same time, I would like to use class 3 elastics because it is very important to have a perfect diagnosis, especially in this case. I need to use a strategical attachments to where the precision, the aligners and the elastics too. And so for me it's very, very important to start immediately, but I know I have many deciduous teeth. So in this case, I started immediately, but I know to follow the evolution of the teeth, the dentition. I want to use class 3 elastics, and you know that it is very important to use a perfect width for the perfect force, a perfect dimension. And I would like to share with you what we have about the rule of 3. If we want to correct, if you want to select exactly the correct side for the elastics, we can use this rule of 3. The right elastics is one that, without being stretched, without, reaches the distance on its relaxed form 3 times. Okay? The distance on its relaxed form 3 times. So in this case, I have a perfect dimension of the elastics following the rule of 3. All in this case, and using medium forces. Finishing the first phase after 5 months of therapy, This is the situation. So strange as a situation. But using these two little pieces of plastic, we are able immediately to reduce the interference, immediately to have a new position for the mandibular bone. Because we are able to do a perfect diagnosis. This is the overjet after 5 months of therapy. And this is the evolution of the profile. Immediately the position, immediately the new situation about the profile. I have the second X-rays. I know I need to improve better. I have many problems about the canines of the upper arch, but I would like to share with you what I found using the cephalometric value about Arianna and the improvement of the class 3 malocclusion immediately. From less than 3 degrees to 0 degrees, and this is the value of the width, less than to less 2. And using the second phase, of course, because I'm finishing the second phase, other 8 months of therapy, following the evolution of the dentition. This is what I had at the beginning of my treatment, and this is what I had at the end of the second phase, starting the third phase. This is the real situation. Other phase, following the third phase, 5 months plus 8 months plus other 8 months of therapy. And this is the situation at the end. I know that it is not a perfect class 1, but I think this is the overjet and overbite. This is again what I found in the upper arch, the middle line, and the evolution of the position of the mandibular bone, the overjet from 1 to 8 pictures, and the evolution of the face. But it is very important to share with you the evolution of the profile and what I found during the Vivera phase. And this is some pictures that I took after 1 year at the end of the therapy. Stable situation, I think. If these some pictures before and after. This is the smile from the beginning of the treatment, before and after of the profile, and this is the situation before and after, and what we had at the beginning of the treatment and what we had at the end, and the evolution of the arch form and the overjet and overbite before and after. And I had the third X-rays. The third X-rays is what the nature is doing. The nature is doing without nothing special, without appliances, without nothing. So this is the evolution before and after treatment, and the third X-rays many months after the end of all parts of treatments. The evolution before and after, and this is especially about the third part that I would like to note it, very important, to analyze that we have a and B less than 3, to 0 to 2 degrees. The superimposition between soft tissues and skeletal tissues too. And again, I want to sum up about this case so important for me, because I said before during the first cases that it is very important to have a perfect association with the work of the speech therapist. In this case, I followed my treatment, my orthodontic treatment, and at the same time, she was followed by the speech therapist too. Very, very important, because we can have a perfect association, a perfect work all together with the speech therapist too. So it is very important to use a perfect diagnosis again. We need to use again the occlusal interference about, especially this analysis using occlusogram from orthograph. And of course, sometimes we are not to wait for the permanent dentition, but it is very, very important to use early treatment, to use the intercepted orthodontics. Luca, I looked at him in this situation with this type of profile. I know that I have severe debite, and a severe class 2 occlusion with this type of profile. So I have a crowding, upper and lower arch, and you can look at the values from a cephalometric view. I have a severe class 2 malocclusion because I have A and B almost 6 degrees. So I need to go on immediately, starting the therapy. We know that we have many situations, many works, many articles about the way to analyze the vertical vertebral maturation index. So for us, it's very important to analyze the vertical cervical maturation. So important for us, because we have a relationship between this index and the statural height. So important. And we know that if you want to have a perfect supplementary growth of the mandibular bone, we know to use this stage between CS3 and CS4. So I need to analyze Luca, and I found that we are exactly between CS3 and CS4, because this is this type of index from cephalometric view. I have a severe class 2 malocclusion because I have A and B almost 6 degrees. This is the superimposition between soft tissues and skeletal tissues too. I try to move the situation about the mandibular bone, so I think I can improve better the profile using the supplementary growth of the mandibular bone. Very, very important in this case. Only in this case, I need to improve the profile. Only in this case. So I need to analyze that the soft tissues too and the skeletal tissues too. So important for me. So the first step is to have the transversal dimension. So important, because we need to have a perfect relationship between upper and lower jaw in the transversal dimension and in the vertical dimension too. Then I would like to have a supplementary growth of the mandibular bone. So the first thing that I did is to have a perfect expansion for the upper and lower arch. Then I need to improve better the position of the mandibular bone about this to correct the mandibular hypoplasia. And at the same time, I need to correct the severe crowding and to reduce the overjet. So I have many tools in my hands, for example, the clean check, the table of dental movements, the superimposition, the 3D commands, the contacts, and orthocad again, with occlusogram and JA control. So this is a way to analyze the jump, the superimposition between the jump, the dental position, and the mandibular position. But I need to have a pre-MA. So to improve better exactly the situation about the vertical and transversal dimension, about the maxillary bone, I need to prepare the maxillary bone to have a perfect width between the maxillary bone and the mandibular bone, because I need to have a jump for using the MA, the mandibular advancement, but I need to improve better the situation about the upper arch that can accept the new position for the mandibular bone. So I need to have a perfect expansion. I need to have an anterior alignment. I need to correct the deep bite, and I need to correct the mandibular rotation. Exactly with this situation, I need to have more than 3 millimeters about the expansion of the upper arch in compared to the lower arch. Exactly with this, using the perfect width between upper and lower arch, because I need to have a perfect class 1 occlusion, and we know that we have a perfect class 1 occlusion only when we can put the mesial palatal cuspid of the first molar of the upper arch inside the sulcus of the first molar of the mandibular bone. So in this case, using the rotation of the first molars with following the Ricketts line, and to plan exactly the perfect width between upper and lower arch. Using the orthocad, the occlusogram function, I discovered that I have many problems in anterior part. Strong contacts again, and I would like to avoid these strong contacts, this deep bite, severe this bite. For this reason, I can have the perfect position for the mandibular bone. So again, the session and what I had during the session. And this is the situation about the tics and trips. So I need to use mandibular advancement, but I need to have a pre-MA to eliminate all occlusion interference, to have two jumps about 2 millimeters, because this is the perfect protocols that we can follow using the mandibular advancement, to jump about 2 millimeters every 8 stages. So we need to correct the strong contacts in anterior part, and we need to limit the proclination of the lower incisors, so we can put IPR in the lower incisors. After 6 months of therapy, using the precision wings for Luca, and he is wearing in this picture the precision wings. This is, of course, again the session and what I found during my second scan. The correction of the deep bite, exactly from clean check 2, following the planning. And this is the second X-rays with the AMB 2 degrees. So the normal degrees about the class 2 malocclusion, the correction, And exactly what I found this. A and B, 2 degrees. In compared to when we started, 6 degrees. This is the evolution. And what I found, I have a perfect supplementary growth of the mandibular bone. Exactly what I planned at the beginning of my treatment. Before and after. And again, you can recognize, not only analyzing the correction of class 2 malocclusion, not only analyzing the cephalometric values, but also looking at the distal plans of the first molars. And this is the superimposition between after 1 year and a half of treatments. The evolution before and after, and the supplementary growth, and the new profile. The end, some pictures at the end, and this is the situation at the end. The relationship between upper and lower jaw, the evolution of the overjet and overbite, and the smile and the soft tissues too, the lips, and the position of the incisors, and of course the third part of on my face with this type of difference between before and after treatments. And you can look at again the negative posterior torque that we can correct immediately with these perfect plans about the expansions before and after treatment, the overjet and overbite. Sorry, and this is the end of my treatment about Luca. I would like to share what I did with Cristiano, because this is a case that I didn't find between CS3 or CS4 index, but using a perfect diagnosis again. I have a severe class 2 malocclusion, but I think this position, the mandibular bone, is due to of this strange malformation, alteration of the incisors, especially on the left incisor. I think this is a forced position of the mandibular bone. Due to this fusion, this strange alteration about the incisor, the central incisor on the right side, but we are exactly at the end, between CS4 and CS6 on my growth. But I need to start again using, of course, my diagnosis, using my way to analyze the interference. I don't know what I can do. I don't know if I need to use elastics. I need to use mandibular advancement. I don't know, distalization, extraction, or surgery. I don't know. But using the analysis of orthocad and again the occlusogram, I have these anterior strong contacts, and I'm so sure that this type of position, the mandibular bone, is due to a forced position. And you can look at immediately using orthocad that we have these strong contacts in anterior part. In this case, I have an anterior strong contacts, and I recognize that I need to have an improvement about the upper expansion. So the first thing, again, I try to analyze the 3 dimensions. And of course, I need to have at the beginning an expansion of the upper incisor. Then I can have a new position for the mandibular bone. So I need to improve exactly at the beginning the width between upper and lower jaw. So this is the situation, and you can look at what I found after the elimination of that alteration of the incisors. And this is the evolution of the clean check using class 2 elastics, using the flattening of the P curve with the extrusion of the middle part and intrusion of the incisors at the same time on the upper and lower jaw, with the extrusion of the middle part of the lower arch and intrusion of the incisors. And this is what I have at the final contacts. I don't want to have in anterior parts the contacts. I don't want to have the contacts in the buccal cuspid of the upper arch. I don't want to have contacts in the inner side of the buccal cuspid of the upper arch. This is my plan. This is what I would like to have at the end of my treatments, especially when I have a severe class 2 malocclusion. I don't want to have more proclination for the lower incisors. I prefer to use IPR and to have an expansion in the intermediate part and IPR. Exactly what I planned. The perfect width between upper and lower arch, between these 2 points, between this, the mesial palatal cuspid of the upper arch and the sulcus of the lower arch. I need to have a perfect width between upper and lower arch. So without overcorrection, because we are in a growing patients. And I need to analyze exactly what we have in the buccal cuspid of the first molars and the palatal cuspid of the first molar. They have to be at the same level. Only in this case I have a perfect position about the crowns and about the roots. Only in this case. So this is the last view. We have to have this analysis, especially in the lateral view. So using orthocad and occlusogram function, we need to identify the interference and to analyze the transversal dimension. So the first is this, transversal dimension. Then we need to level the P curve. We need to reduce the deep bite. This is the second analysis. And the third is using all things that we can improve about the sagittal dimension. So we need the elastics with the medium forces and with the strategical hooks and attachments. This is Cristiano at the end of the 7 months of therapy, with the great improvements about the class 2 malocclusion, the deep bite, and this is the end. Of course, a perfect situation about the overjet and overbite, the expansion about upper and lower jaw, and the new position of the mandibular bone. And you look at immediately what I found, 3 degrees, so class 1 occlusion, before and after, the evolution, before and after, and the soft tissues too, before and after, the superimposition between the soft tissues and skeletal tissues too, and the smile. So nice, this type of smile with this correction of the deep bite too. The improvement of the soft tissues. And look at the severe deep bite. Look at the super negative posterior torque. look at this class 2, severe class 2 malocclusion and the perfect correction about the deep bite, about the class 2, about this negative torque, posterior torque, etc. Before and after. So I used the first phase about 21 aligners, the second phase about 14 aligners, and now we are using the Vivera. So for me, it's very, very important again to use the occlusogram, to use the analysis of occlusogram function in orthocad, and to prevent to use immediately my mind on eliminating of this interference. So important for me because many malocclusions are due to this type of interference. So this is very, very important for me using the Invisalign system in cooperation with functional appliances, with the functional therapy, myofunctional therapists. And at the same time, I think Invisalign technique we can use as a functional therapy too. So important because with these two little pieces of plastic, we can avoid immediately interference. I need to share this slide with you because I think we are able to change our mind. Only in this situation we can go on, only if we can accept the change. So I like these pictures and I like this slide for this reason, because only if we are able to accept the change, we can go on. And I would like to thank you with my kids too. And this was a great honor to be with you. Thank you very much. Grazie.